So thank you very much. And I want to make sure that everybody understands the little dig we have from Brian Donovan there about me trying to keep on track. So look, I'm going to talk to you today about developing a HSE payment platform for the purchase of waiting list procedures. And people might think that sounds familiar, and it is familiar because it's exactly the same title as we had last year, but we have done an awful lot of work on it since I spoke to you about it at the conference last year. This is a presentation that's been given by me, but it's really a presentation on behalf of the software development team and the HPO IT, because I do very little like this. The software development team do all the work on this. So I just want to acknowledge that. I'm also going to touch on a couple of other things as well, but primarily it'll be about that. And so that's why I expect Brian to have a shepherd's crook to drag me off the stage eventually. So just to mention that as well. We're going to talk about hype wars just very quickly, and we're going to talk about ARDRGs because it's important for people to understand the process we're going through in terms of ARDRGs and where we're going with those. So the first thing to say about the Access to Care program is, what they're doing is, what they're using it for, what we're looking at it for, is the funding of public patients in private hospitals. But they actually do a lot more than that. They also spend money funding patients' additional activity in public hospitals, and they look at patients on the waiting list and maybe review them on the waiting list. And there's other activities as well. There's a lot of things, they have different names for it, like non-recurrent funding and SIPs or Sláinte Care implementation plans and stuff like that. So a lot of that work has been done by them. It is complementary to the NTPF work. So this is not a replacement for NTPF in any way. This is complementary to the NTPF work. And so I just want to be clear about that. And what we're doing here is we have a series of procedures that have been gone out to procurement, and we call them products. And we've gone to the private hospitals in the part that we're working on and said, tell us how much it will cost to actually do this procedure. And once they've come back and told us, and so we have everything based on a procurement process. We have certain rules in terms of the part that we're doing. They have to be the longest waiters. The patients, they have to be clinically suitable, and they have to be waiting on the waiting list for something that we have in the procurement. We can't send them to a private hospital for something that we don't have a cost for, because that wouldn't make sense. The overall process then, what we do is a suitable patient is chosen from the waiting list. The patient is issued a UAN and referred to the private hospital. And once they go to the private hospital then takes over their management of their care. They schedule the patient, they bring them in, they admit them, they treat them, and they discharge them as normal. Then what happens is the private hospital submit a claim to us. So that's like the health insurance claim. They send us in a claim through our systems, and we adjudicate the claim. And generally speaking, for the majority of them, there's no adjudication. It just gets checked. We just get them get paid. And once we're happy with the adjudication, once we're happy that we understand what the cost was, we pay the claim. And it was mentioned earlier on that people are quite happy with the system, and the reason is because we're doing this fairly seamlessly. There's no big delays in the system as well. Just looking at the different software parts, then the bits that we've added, the HPO have added to this. The UAN system and the waiting list system is the first part. That's what we call it, the UAN system, and we've imported some information from the waiting list as well. The second part is the UAN system itself. Then when we come to the treatment and then the claim, that's the HSE claim system. And then we have, when it's adjudicated, we have the claims management system. Then finally, when it comes to payment, we have an interface where we've built to allow us to connect to the actual SAP payment system, which will be IFMS in the next couple of days. And very importantly, we have all the data that's associated with this. And so we were able to do reporting on it. And the reporting is really the central part of this, and it is very important. And I was reminded this morning about 7 o'clock, so we get emails every morning at 7 o'clock. So when I was lying there, a little bit hungover this morning at 7 o'clock, my phone started beeping. So I must remember to thank the reporting team for that. But more importantly, what it's doing is taking the data and turning it into information and knowledge. And that's the important piece. So just talking about the UAN system itself, what we're dealing with is it's a system that allows the public hospitals to choose the patients and send them out to the private hospitals. It's being used by the HSE colleagues, the scheduled care people in the hospitals themselves, and it's only accessible. Nobody outside of the HSE accesses it. So it's private, it's public hospitals, scheduled care in public hospitals. A UAN, just so people understand, and we refer to it as UAN, not UNA or anything like that, but we refer to them as UAN. A UAN is a unique authorization number, and the idea is it's for a referral to a private hospital. A single referral to a private hospital. If a patient is on the waiting list for 2 things, they will get 2 UANs for those treatments. So, as I said already, the patient is chosen off the waiting list. They have to be clinically suitable. The private hospital has to accept the patient. We can't just send them to the private hospital and hope that the patient will be treated, because they're being paused off the waiting list, suspended off the waiting list when we send them. So they have to get treatment. And also the patient has to agree to attend. There can't be a case that the patient decides they don't want to go. So what does it look like? It's the version we're looking at on the screen now is the version that we're going to send out very shortly. It has made a couple of small changes around the budget at the top and I'll speak about that a little bit later on. And we're also now we're aiming to collect a referring consultant as well, just so we have that additional piece of information. But the rest of the information, we know what the patient type is, they're an adult or a child. We know what treatment type they're going for, day case or inpatient. We know how long they're on the waiting list. We know when they were put on the waiting list, and we know what they're being sent for. And they're all very important pieces of information. Once we send them, or once we've decided they can go, that they're clinically suitable, then we go through a matching process where we're saying, well, look, we're asking the patient, are they happy to go to a particular hospital? And we're asking the hospital, are you happy to accept this patient? And just to make the point that the hospitals are in a certain order. The order is based on which hospital was scored best in the tendering process when the tendering process was done. So the first hospital is the one that would expect to get the best because they scored best. Moving on to the next part of the software system is the HSE claim system, and this is essentially a claim form. So anybody here who's been unlucky enough to go through hospital and have to go through VHI or Bupa or LEA, you'll have remembered that you've been asked to fill out a form, and a form has been filled out on your behalf, and a bill has been sent. So this is electronically what's the same idea, and as soon as a UAN is generated, a blank form on the system is created. And the kind of information we're collecting here is typical, the same typical type of information that's on the health insurance form. And I know this because we designed it based on the health insurance forms. So this is the same type of information we're collecting. Because they're private hospitals, because they're outside of the HSE network, they will have to access it through typically Citrix. The hospitals have to access it through Citrix. So there's an overhead in terms of that, but that's a welcome overhead because we're treating patients. Each claim is a single treatment. Now, when I say that, there are a couple of claims that for UANs where there's multiple treatments because of the nature of the product, the nature of the procedure, that it happens a couple of times. But each claim generally is a single treatment. And the private hospital, once the patient's been treated, they submit it, and they have to submit an invoice as well. There's a series of sections in the actual HSE claim system. We have a hospital admin section. We have an accommodation section dealing with wards and what kind of wards the patient were in. We have a diagnosis section, some clinical information about why they're in the hospital, a procedure section, some information about what happened to the hospital. Anybody here who's familiar with HYPE knows exactly where this is going. And Brian was alluding to this earlier on. This is what we're looking at. We are collecting enough information so if we have to create a HYPE record, we can. We have a discharge section. We have a finance section, to allow the hospitals to actually tell us how much it actually costs, just in case it's different to what we expected it to be. And then there's other additional information that allow us to actually, for them to justify why it's a different value. So just some screenshots of that, I'll just zoom through them. The hospital admin section, just to give you an idea of it, and can I just make the point again that this is all developed in-house by my colleagues, the software development team. So the hospital admin section, some of the information we collect there, the location, the wards, what kind of information we're collecting there, diagnoses and procedures, and we can collect additional diagnoses and additional procedures. So if a patient has to spend longer, there might be a complication, and we'd expect to see that in the diagnosis. If there was a medical necessary procedure to be done when the patient was in the hospital, we'd expect that to be recorded as well. And if all that meant that the patient was in longer in hospital and is costing more, then this is all part of the adjudication. the people who will do claims management, which I'm going to move on to in a second, will look at this and say, okay, I can understand why the patient was in longer. So we have a finance section, and one of the pieces we actually collected is actual cost. And in most cases, the actual cost is what we expected. We have gone to the private hospitals and said, how much does it cost to have procedure X done? And they've said, it's going to cost so much money. So that's what it comes up with. But if the hospital then turns around to us and say, well, actually, there's an extra €500 because the patient had to spend overnight, or we had to get an ambulance for the patient or something else. And if it's medically necessary, the claims management will accept it, or else they'll go back and they will query it. And this would be a similar concept, a similar procedure that you see with health insurers as well. You'll be aware that health insurers would do this as well. And the additional other information, if anything is different, if it's not what we expect it to be, if anything is different, we expect something in that box. It's nice and big on the screen, it's nice and big on their screens, we expect something written on that box. Moving on to claims management then. So this is how we manage the claims, right? The first thing is that if the claim is submitted and the value is what we expect it to be, so we have procured the procedure for a certain cost and the private hospital has submitted that cost and there's no difference, then an automated process just puts it straight through and it's processed. But if they make a change and to be fair to the private hospitals, they don't randomly make changes. There's usually a reason for making a change. Then it becomes what's called an outlier. And each of those claims then, the outlier claims, are assessed individually. We look at them. We look at the diagnosis. We look at the procedures. We look at any additional information. We look at the invoice. And we have a look and see, does it make sense? So we're not talking about kind of that they got special rooms or anything like that, right? There has to be a medical necessity for what was done. And we will go back to the hospitals and ask why it is. And if they give us a justifiable answer, then we say yes. If don't, then we have I won't say an argument, we have a discussion with them. What does this look like on the system? It is a HSE based system, so the claims management is based within the HSE. What does it look like? You can see it there, you can go through it and you can look at the information, you can look at the invoice, you can look at the claim that was submitted, and then you have a button there to approve or to reject the dispute, rather, the claim. Moving on to the payment system as well. So what we have done is we've developed a system that it interfaces with the existing SAP system. And this, of course, will shortly be IFMS. And what we've done is we've set up all the hospitals to be vendors on that system, on our system. So we have a series of vendor numbers. We have all the details to do that. So what happens is that the budget holder who's in HSE acutes, we send them a list of the claims that are going to be paid, and we ask them to just have a check through them. They do a level of due diligence on them, but bearing in mind that they've already gone through a series of steps, right? They've gone through things, so they haven't got to the point of payment without us checking it first. And then once they're happy with the claims, and when they will sign off, and they'll come back to us and say, yes, we're okay to go ahead with that file and send it to the SAP system. And then what we do is we send the file to the SAP system, and there's a further thing where we confirm with HBS payments that the file can go ahead and payment, and then it just gets paid through the normal systems. So there's some slight changes, nothing major, but some slight changes for IFMS. And so when that happens, which is coming down the line now very shortly, we'll have to make some changes to the system. But primarily it's around the vendor. We'll get new vendor numbers. Reporting is the key part of this. There's various types of reports that are generated on a daily basis, on a weekly basis. The first one is a full data report on the UAN and HSE claim system. We get all the information. We find out what patients being sent for, what procedures to what hospitals, how much value is being used, what patients. We have budgets against each hospital, and we know how much of the budget is being used. The private hospitals get reports on how many referrals have gone to their hospitals in the last 24 hours. So it's not just a case of the claim just appearing on the system. They know this coming through as well, and they can start the process. We send warning reports to the public hospitals when they're hitting their budgets, and so that they know they're hitting their budgets, and they might it might allow them to make particular decisions about which patients are going to put forward through the system. We have financial reports for the current year, and for accounting purposes, our colleagues in the acute finance require those reports so that they can account for the finances of it. So we have reports from that. And I mean, I'm going through them all there, but really what's important here is because we're collecting all this data, because we have the data in the UAN system, we're collecting the data in the claims system, because we have all this data, we're able to generate all these reports, and we're able to see the value, the information that's going through the system, and how we're spending all this money. We have a report on the operation of HSE claims for acutes, and a report on essentially for auditing and monitoring, and then an overall report for monitoring and auditing as well for HSE acutes, and then a weekly report that's sent to our colleagues in EY. EY do some help with us as well on this. Just some numbers here now. There's no rhyme and reason to these numbers, just some random statistics. The number of public hospitals that have been involved in the system this year is 16 hospitals. The number of private hospitals is 9 hospitals. The total number of referred patients is just short of 1,500 patients, 1,429 patients. And the total value of referrals is 15 million, nearly 16 million. Now, bear in mind that their referrals, some of those patients haven't gone through the system to be paid for yet. They're patients who have been sent rather than patients who have been paid for yet. The number of patients discharged this year is 410 patients. Inpatients discharged is 410 patients. And the total bed days is just short of 1,500, 3.5 is the average length of stay. The number of day cases is 386 this year as well. And the value of the cases discharged is just short of 10 million. The difference between the 15 and 10 million is that some patients are still about to be admitted. So we know that there's going to be a cost for them. It goes into their budget because we know there's going to be a cost for them. But the 10 million are people who've been discharged. We know they've been discharged. And the average waiting list time for those patients is 241 days. So these are waiting list patients in the majority. So just some thoughts on the future of the UAN system. A new version of the UAN system is going to be released very shortly. We were hoping to get it done last week, but probably this week or next week it'll go out. And so some of the things we're looking at, we're investigating the idea of collecting information on non-recurrent funding. Non-recurrent funding is where hospitals are sending patients, they're insourcing patients to their own hospital, and they're getting additional money. And we need to understand what patients are being treated and how much that's all costing. So that's why we're hoping to expand the UN system for that. So we're investigating that at the moment. We've done a good bit of work with our colleagues in HSE acutes on that, and a bit more work to be done on it. We're also looking at using it for medical beds. There's a challenge with medical beds because we need to understand how much it's going to cost, and often if somebody's been sent for a medical bed, it's usually open-ended. You can't say for definite it's going to go for 10 days or 15 days. And then we're also working with the Women's and Infants Program to talk about IVF. There's a new process, a new procedure, a new project rather being introduced at the moment for IVF, where public patients are going to be sent to private institutions. And so they're going to use our system to actually pay those private institutions. So that'll be one of the interesting parts about that is the fact that the payments or the actual budgets is slightly different because of the way the actual IVF process works, and also then that we'll deal with non-hospital entities as well. Some of them will be hospitals, but some of them will be just clinics as well. We also have been working on a new tender, and it's anybody who's involved in procurement. I'm sure you're all very used to the idea of how long some of these things take, and it has taken quite a while. So it will update the prices, which is good news. Well, good news for private hospitals probably, but not good news for HSE. It will expand the number of procedures available and expand the hospitals available as well. It's been announced. I mean, the responses have been received and they've been evaluated, and the outcome is being worked on by HSE procurement at the moment. So we're close, but not there just yet. And there's a few more steps that have to go, but we expect it to go live a little bit later on. And that will greatly expand the number of procedures available. So it means more patients off the waiting list will be able to go through the system, and will greatly expand the number of private hospitals who can do this. And we're also looking at building a governance structure around this as well, just because we need a governance structure to make sure that we understand where this whole system is going as well. So a steering committee will be done as well. I should say at this point now, I'm always very low to start naming names, but some of the people who are involved in this, I really have to thank on this. So Brian Donovan, who's pushing this along, Phil, Pavel, Richie, Shane, Joe, they've all been doing all the work as well. Marianne, who I know is here, and Orla, they've been from HSE Acutes, they've been doing a pile of work on this as well, and they really have been driving it along. And Mike Corbett is not here. Sarah Power, Mairead Tuig, another clinical colleagues who are all involved in procurement. They've been really helpful as well, and they really have helped us move this project along. And then our EY colleagues as well. So just to in summary, I mean, what we're doing with the overall process is we're selecting patients, referring them, scheduling them, admitting them, treating them, discharging them, getting a claim, adjudicating the claim, and reimbursing them. And I just want to emphasize again that the system consists of a series of pieces of software which provides the facility to do all this. It's like a facility to procure, to commission this, and then pay for them as well. And that hasn't existed. Brian mentioned earlier on that we had to use the VHI to pay for some patients during safety net because this system didn't exist. And one of the things is that the system is adaptable, it's agile. So it allows us to have new uses like the IVF, like the medical beds, and to have changes to the payment systems. So I do have two more topics, but I'm going to deal with one of them, and I'll leave you to read the rest of them then on the slides we make available. I just want to talk about wards as well, just to explain to people what we're doing with wards, and then I'll leave it at that. So considerable work is underway at the moment in reviewing wards and type system, and one of my colleagues, Joe Hunter, is doing a lot of work on this at the moment. The wards need to be reviewed to see if they're still valid. I mean, some of the wards have existed for 20 years, and we're just not sure if are they still hype wards? Have they still hype activity in them? There was a lot of repurposing of wards during the pandemic as well. We saw that. We were having meetings weekly because we were getting queries about wards all the time. And we see there's changes in wards in medical practice, and also we can see that some of the activity might be moving because of other collection systems, into other collection systems as well. So we're conscious of that as well. So hospitals are being contacted about wards where we see nothing happening in the wards, right? That is a data entry check thing we have to do. If we have a ward that's not there, there's always a possibility a coder may accidentally choose that ward. So it may cause a data entry error. So we're contacting hospitals to retire the ward so that it's no longer available for the coders to actually use, and it is a data quality initiative. And we are considering the possibility of actually automatically retiring wards after 3 months. We haven't made that final decision yet. I have to emphasize again, and I have said this in emails to people as well, is that we're not making any comment about what's going on in the ward. We're not making any comment about how the ward should be used in the hospital itself. All we're saying is, from a high point of view, we don't think the ward should be collected. So I'm going to leave it there. I was going to talk about ARDRGs, but I'm going to leave it there. But the ARDRGs is fairly self-explanatory, and I'll let you look at them in the slides as well. It'll give you something to do on the way home. Thank you very much.